All right, good evening, guys. Dr. Bosire is my name. Thank you for joining us today for our presentation on role of Tivortin in management of preeclampsia. Our hosts today are through COGS Harleys Nairobi. We also do have Professor Sikolia Wanyonyi, a local first MFM certified, of course, Sikolia Wanyonyi at Aga Khan University. And we also have Professor Yulia, who's a professor in the university in Ukraine, in the Institute of Pediatrics and Obstetrics Gynecology, who's going to take us through the management of preeclampsia with this new molecule. We want you to be as interactive as possible because preeclampsia is something that we really are exposed to. And I think we're at the stage where only medication we're using is just, methyl dopa, nifedipine, labetalol. Can we do something else? Can we do something else in management? Can we do something else in prevention of this this condition? And especially in all of us knowing how severe this condition is in our setup. We ask that you ask questions. You can put questions on the chat if you want to be clear. At the end of the sessions, we will be able to have a question and answer session. So if you have a really pressing question, put it on the chat. And then during the live question and answer session, we'll be able to answer it. Rules is that I think the host will be able to unmute you when that time comes. Ask anything you want. These guys are specialists. These guys are Omesoma, they have read, and we need you to leave this webinar having known something. So to start us off, I believe that we should have Professor Sikolia. I hope that's the title that's now official. Prof. Sikolia has been, I think, practicing in the Aga Khan University from around 2005 in the obstetric department. He graduated, I believe, and was able to subspecialize in maternal-fetal medicine. He's attended schools in the UK and also the University of Barcelona, being the latest attachment that he had. He is a member also of MRCOG, and he's here to take us through his presentation. So, Karibu, Professor.
Okay. Thank you very much, Harleys, for this invitation. And just a correction, Dr. Bosire, I'm not a professor. My name is Dr. Sikolia, and I'm a consultant at Aga Khan Hospital in obstetrics and fetal medicine. So today, this evening, I'm going to take you briefly in the next 20 minutes or so through the journey of preeclampsia from prediction to prevention. And then I think Professor Yulia will touch on the core of the matter tonight. So this is Aga Khan University Hospital where we are based, and our fetal medicine unit is based on the first floor of this building over here. And I would want to kick off. I won't go much into the basics of preeclampsia or the prevalence, because I believe we all know that. My main focus today is to try and share with you how we can be able to determine those women who are at risk of preeclampsia so that they could eventually benefit from the various preventive mechanisms which are currently available. So risk calculation generally, as we all know, for preeclampsia, like any other condition, is usually derived from both the history and a combination of other factors, including biomarkers in the case of preeclampsia. So the useful biomarkers in preeclampsia usually will be done at around 11 to 14 weeks. And remember, the reason we want to determine risk is to be able to do that early enough in pregnancy so that we catch those women who will actually benefit from prevention, because there is no point in determining these risks later on when you can't actually be able to do anything. So focus is now shifting more towards determining these things in the first trimester. And 11 to 14 weeks is actually a very optimum time at which we can be able to do this. Some of the basic things you can be able to do is something like the mean arterial pressure. I'll be taking you through the various factors. And then we have the uterine artery Dopplers, which you can do the pulsatility index at this gestation. And then we have the serum markers like the placental growth factors. And where placental growth factors is not being done, you could actually use the PAP-A from your first trimester combined screening results to be able to determine the risks. Now, the thing with the serum markers is that they do vary across populations. They do vary dependent on the maternal characteristics and also the laboratories performing them and the reagent using them for analysis. So to be able to have values that are actually comparable across population and that are meaningful, these have to be converted into multiples of median. And then you use this and feed them into the software to be able to help you determine the risk appropriately. So traditionally, we have dependent on epidemiological risk factors, and most of us still do that. And until recently, most international bodies have actually looked at epidemiological risk factors. For instance, I'm just showing you the two criteria that were previously used by, just a minute. So the epidemiological risk factors have been classified into major and minor criteria. So the major criteria are as listed, and these vary depending on the body which you're looking at. For instance, the NHS, which is the UK body, lists like renal disease, autoimmune disease, and all that is written, including a history of previous preeclampsia. And then we have the US task force actually putting multiple gestation as a major criteria, whereas it appears as a minor criteria in the NHS. So these are epidemiological risk factors which still do play a role in determining risks, as I will share later on. So how accurate are these risk factors? As you can see, the major risk factors, as much as they're called major, are not so accurate. What we're showing here is that, for instance, if you looked at multiple gestation alone as a risk factor, you'll only be able to accurately determine risk in 3.3% of the women. While you find a factor like priming gravida actually plays a major role, then the question is, how accurate is this? Does it mean that women priming gravida is just Rajesh? Sorry, that was part of our skipping. As I said, it's very conflicting. So you find that there is a lot of heterogeneity in using epidemiological factors alone to determine the risk of developing preeclampsia. So if all of them are combined, someone would argue, what if you combined all of them? So you had this piece of paper, this questionnaire, software, whatever you want to use, and then you take all these risk factors, then put them into an algorithm. How accurate will you be in detecting those women who are at risk of developing preeclampsia? So all these combined actually perform very poorly, and we are looking at ending up missing about 50% of all the women who are at risk of developing preeclampsia. So looking at a woman who had preeclampsia alone will actually, you'll end up missing significant risks that may have put this woman at the risk of developing preeclampsia. And as you can see, the false positive rates are quite high. So that means that as much as you are missing out many women, the few that you're actually including in your cohort will end up being falsely put there. So you have women who are not actually positive being classified as risk positive. That said, we all are aware of the origins and the consequences of preeclampsia. We all know about the different factors that contribute to the eventual damage to the endothelium and the various consequences of preeclampsia, which I'm not going to touch on, but I found this screen to be quite relieving and a better snapshot of understanding how this maternal syndrome comes about. Of course, traditionally, we have labeled it as a placental disease. Things are changing, and there are new schools of thought which tend to think that this could actually be a cardiovascular disease that manifests with the placenta. So to carry on, what actually happens eventually for these women to develop preeclampsia? So as shown here, the final damage that happens in preeclampsia is the damage to the endothelial cells. And this damage to the endothelial cells is what results in different pathologies that we do encounter. That is the CNS, the renal, the hepatic, all the organs that are affected eventually in women with preeclampsia. So the uterine artery, which I had mentioned earlier, still plays a major, or rather plays a major role in the pathogenesis or development of preeclampsia. And we know about the modeling that happens during pregnancy. A woman has to change from a pre-pregnancy state. So we are looking at the uterine artery, which was a very high resistant vessel being remodeled early on in gestation to become a vessel of less resistance so as to allow blood to flow into the placenta. And this happening even further as the pregnancy progresses into the early third trimester. So we know about the trophoblastic invasion that takes place, and this is actually mirrors what happens to the uterine artery. So my schematic presentation here, you will see that this is a normal uterine artery in an unpregnant woman, but between 6 to 12-week gestation, there is a change or activation of these cells to become more compliant. So the resistance is reduced and they become low velocity vessels. And this actually progresses on into around 24 weeks gestation when it becomes a very low resistant vessel. And this allows clear flow, or rather smooth flow of blood into the placenta. And so what is the significance of this? The significance of this is that, as you can see from the previous slide, if you were to look at these three phases, one would say that it is at this last phase, at between 16 and 24 weeks, that one can conclusively say that the uterine artery has remodeled enough for me to say that it will be very compliant and enable smooth flow of blood into the uteroplacental space. And this has actually been looked at. And it's very true that if you took your uterine artery measurements at between 19 to 24 weeks, then you'll actually be able to reliably detect women who are at risk of developing preterm preeclampsia, that is before 34 weeks, very effectively, to the tune of 75 to 80%. And overall, women who will develop preeclampsia regardless of the gestational age by about 50%. So performing just as good as the epidemiological risk factors. However, how useful is this? We look at that later, because you want to predict in order to prevent. So if you predict at 19 weeks, 20 to 23 weeks very reliably, will you be able to do anything? And the answer, as you'll see later on, is no. You'll be able to know this woman will develop preeclampsia. So you've done your anomaly scan, you've requested for uterine artery Doppler. The uterine artery Doppler has told you that the pulsatility index is increased. So this woman is at risk of preeclampsia. That is correct. But what will you be able to do with that information? So how do we improve this? If you cook, you will agree that you can make a meal in different ways. Yeah, you can take, for instance, chicken or turkey or whatever you like, and throw it into the oven, and then come back, set it to 30 minutes, and come back after 30 minutes and get your chicken out, and it will be ready to eat. Yeah, but someone else would take that chicken, marinate the chicken, add in a few spices here and there, poke in a few things, and then drop it into the oven and come back after 30 minutes. And the chicken will actually be better than what you had before. So the same applies to medicine, and the same applies to the concept of predicting conditions. So the more input the more things you put in, the better the results, the better the test. So what would happen if we only took the uterine artery Doppler and then combined it with the epidemiological risk factors? If you do that, then you see from these rock curves that this actually increases your sensitivity much higher. So by combining the epidemiological risk factors and the uterine artery Doppler, which you did earlier, because if you do the uterine artery Doppler at 11 to 14 weeks, the predictive ability is very low. But if you combined it with epidemiological risk factors, all those questions you ask, then you increase your detection rate up to about 70% with the same false positive rate. And going further, so I'm really sticking to things that we can actually do locally before we go on. So far, the two are available. So we are actually able to predict preeclampsia effectively up to 7 out of 10. So the other thing that can be used is the mean arterial blood pressure. So if you have a good automated machine, which is been calibrated well, and you use it at 11 to 14 weeks when these women are booking their clinics, you will actually be able and use it alone. You take your blood pressure measurements alone at 11 weeks. You will be able to predict the onset of preeclampsia by about 50%. Because, as I said earlier, there's emerging evidence that the maternal cardiovascular dynamics actually play a big role in the pathogenesis of the preeclampsia, leading to the eventual dysfunction in the placenta and the intrauterine cells. So blood pressure measurements taken appropriately on two arms in a resting position, and then you take the mean arterial pressure of both arms is actually a very powerful tool that can help us predict preeclampsia much better, actually, than the epidemiological risk factors, because you can see that the risk of prediction, the detection rate is about 50% for early onset preeclampsia with a much lower false positive rate. So combining all these things together, we have so far, we have the epidemiological risk factors, we have the uterine artery Dopplers, then we've added the mean arterial blood pressure. If you plot this on a ROC curve, you realize that this has actually increased your detection rate much, much more. So with these three factors alone, which you have at your hands, you should be able to predict preeclampsia effectively and about 80% by a factor of about 80%. So now we go to the biomarkers. Pregnancy is a very dynamic state. There are many things that happen during pregnancy. We have so many placental chemicals being produced, enzymes being produced, which actually do affect the well-being of the mother and the fetus. So the commonly used biomarkers that have been looked at are the placental growth factors, the S-fleet, and then we are looking at the PAP-A. Now, for those who perform first trimester screening using the conventional combined test, you may request for PAP-A as part of the double test or the combined screening. And using PAP-A, which is which are released actually by the placenta, using these alone, you can actually be able to again predict the risk of preeclampsia quite reliably by about 50%. However, there are other more sensitive biomarkers because the PAP-A was not meant for that purpose. This was just coincidental finding. And the biochemical markers that have been extensively looked at are the placental growth factors and the S-fleet1. So we know that the placental growth factors actually do increase during pregnancy because they're angiogenic. Yeah? They do help in the angiogenesis. They help in the remodeling of the uterine artery. So they are pro-pregnancy. And then we have the anti-angiogenic, which are the S-fleet1 especially. They have an anti-angiogenic effect. So there has to be a balance between these two factors for pregnancy to proceed uneventfully without having any damage to the placenta or to the neovascularization that happens. So if you take these two, yeah, either you can use the ratio, but most sensitive is the use of the placental growth factor alone. So if you include the placental growth factor as a biochemical marker, you will actually increase your recipe, even make it even much sweeter and more pleasant. So you can see by including the PLGF, we are actually able to increase our detection rate from paltry 50% that we had in the beginning to now almost 90%, maintaining the same false positive. So what I've just presented to you has been extensively looked at, and the algorithms have been extensively studied, and most of the bodies, including the ones I showed you at the beginning of these presentations, actually shifting towards this. So we can no longer just look at the epidemiological risk factors to determine the risk of a woman developing preeclampsia. We have to look beyond that and have a bigger recipe that will help us to be more accurate. So with that alone, meaning that if you have a detection rate of 90%, it means that you will catch a much larger population that will benefit from the preventive measures that we'll discuss with you later, and without having to waste resources by using them on those who are undeserving. Now, what is interesting, and this is something that you are going to be seeing in the near future coming up very, very common, is the use of the ophthalmic artery. And this is the maternal ophthalmic artery. So what we do is using a linear transducer of the ultrasound, you actually scan the ophthalmic artery of the woman. And it's actually a very simple procedure, which you can do when the woman is lying and has come for other things, and when she's pregnant. And this has been looked at extensively, and it's been found that it actually compares the uterine artery, in terms of predicting the risk of early onset preeclampsia. So this actually throws the spanners into the works where we question, could preeclampsia be a pre-existing maternal condition that is just aggravated by pregnancy? We are looking at a good example we usually give is an athlete in E10. Telling an athlete in E10 to run a marathon and telling, I don't know, someone else who is an officer, who is someone who is working in a corner office somewhere in Nairobi and is always being driven home every evening and taken back to office in the morning with very little exercise to run the same marathon. Of course, this person who is living a sedentary life will not be able to do even a kilometer. While the person who's been exercising all along, their system has actually adjusted so well that they are able to tolerate that exercise. And this is what happens in pregnancy, because once you become pregnant, you had your body and you're there. And then there's this all changes. You're talking of 40% increase in cardiac output, pumping into you. How are you able to tolerate if you are not well prepared before? So the fact that the ophthalmic artery actually does perform just as good as the uterine artery is a very interesting finding that will actually be a very interesting thing to look at and maybe include it in this risk calculation to increase the flavor. So there are free online calculators. So all these things I've talked about can actually be used in your practice. And there are these free online calculators from the Fetal Medicine Foundation. All you need to do is to input all those things I've talked about. So you put the maternal characteristics, taking care of the epidemiological risk factors, and then, of course, with the correct dating of pregnancy. And then you input the biophysical markers that I talked about, and then you press calculate risk. And you don't have to have the PLGF, the PAP-A. If you do not have those, you leave it. If you have them in MOMS, you put. If you don't have them in MOMS, when you put your raw data, it will be able to calculate for you automatically and give you your MOMS. And then from there, you click the calculate button and voila, you'll be able to get your risk. And when you get your risk, it will actually tell you, for instance, in this example you used here, you find that the woman we put these factors in has a risk of preeclampsia from history only of about 1 in 5. But when you put all the other factors, it's about 1 in 100. So looking at this combination, we're able to say that this woman is not actually at a very high risk of developing preeclampsia and therefore does not need or will not benefit from the preventive measures. So some of the preventive measures I would like to talk about as I wrap up is aspirin. And aspirin has conclusively been found to play a major role in preventing preeclampsia. Now, the thing is, if you remember this slide, they say that if you do your uterine arteries quite early, then it means that you are your risk of detection will be low. But if you do them late, your risk of detection is high. But if you do them late, these women will not actually be able to benefit from aspirin, because you cannot give aspirin at this gestation, or if you do give, it will not really benefit the woman. And I will refer you all to this study. I'm sure most of you know about it. This is the aspirin study, which was a ground-breaking study that involved multiple centers in Europe and the UK. And it actually validated the use of aspirin in the prevention of preeclampsia. Looking at these survival curves, you find that compared to placebo, use of aspirin actually did increase the survival rate, or rather delay the risk of onset of preeclampsia. But the question has always been, when do you give it? This was also looked at in these studies, and it was found that it is best given at bedtime compared to giving it later on in life, because if you give it at bedtime, those in favor, it actually did prevent the risk of preeclampsia, yes. But more importantly is that it does prevent the side effect, because aspirin is not always safe, because there are risks of adverse outcomes, for instance, abruptio, and this will be prevented by giving this drug at bedtime. And then we have the question of when do you give it, because I have seen us giving the drug at any time. So studies were done to find out the optimal dose and then the timing of giving the drug. So giving it before 16 weeks is what is recommended, because there is no effect at all in the prevention of preeclampsia. And you can look, and you can see these are very huge studies of about 10,000 women, which show that giving aspirin before 16 weeks is more useful than doing it later on. I'll quickly look at the other compounds that have been found to be useful. And calcium, as we all know, especially in those women who have low calcium intake, or in those areas where the calcium intake is low, could significantly reduce the risk of preeclampsia. So looking at these charts here, you will see that most of the studies were actually in favor of calcium compared to placebo. And overall, calcium was found to perform much better in the prevention of preeclampsia compared to placebo. There have been looks at vitamin D, and unfortunately, it has performed very poorly, either alone compared to placebo. So this side is showing that which is not in favor of prevention of preeclampsia. This one does not. But if you are aware of these charts, you'll realize that the line is crossing 1. So that means that it does not, vitamin D alone does not prevent. Vitamin D plus calcium and placebo does not prevent. And vitamin D and calcium versus calcium alone, again, there is no difference. So I think maybe this calls for other studies to be done, but as it is right now, there is no evidence to support the use of vitamin D in the prevention of preeclampsia. So vitamin D, the omega-3s, which we tend to like so much, do not have a major role. There's another disappointing molecule, and this was sildenafil, that is Viagra, which I think has been used a lot in the neonatal units for pulmonary hypertension. And we thought that maybe we could infer from that and use it to prevent preeclampsia, because it does actually act on endothelium, and it does reduce the peripheral resistance of these vessels. But unfortunately, the results have been very, very disappointing, whereby it was found that it didn't improve at all the perinatal, either the onset of early onset growth restriction, birth weights. It didn't include the crude perinatal outcomes. It did not improve the neonatal survival. To the contrary, it was actually found that it may have an increase, an effect on the pulmonary vasculature, leading to increase in pulmonary hypertension. So the use of Viagra in the prevention of placental disease is, as it is, not conclusive, or rather the evidence at the moment is not in favor of any benefit, actually favoring some element of harm. And finally, as to prepare you for the next talk, I would look at the other agents that have been looked at, that are being actually looked at, and we are looking at L-arginine. And here, the main endpoint, as I said before, was endothelial dysfunction. And we find that endothelial dysfunction is actually the endpoint for preeclampsia, regardless of the etiology. And there are those factors that actually do damage the endothelium, and by reducing the relaxing factors, and or by increasing the vasoconstriction factors. So this is how the endothelial damage comes about. And it's been studied, several antioxidants have been looked at and been found that they could actually facilitate the endothelial function in pregnant women. So we all know about the role of the nitric oxide, and this has been extensively mentioned over the years in its role in prevention or in the etiology of preeclampsia. So new agents are coming up, like the L-arginine, which have been shown to enhance the release of the nitric oxide at the endothelial level. And in long term, they result in maintenance of the vascular tone, improving the flow of blood, and also reducing the permeability of the vessels, hence eliminating effects, or rather the side effects, which are the metabolic acidosis that will result from the hypoxic events that ensue. So my colleague will, Professor Yulia, will be touching on this. So I just threw here a couple of papers I came across, which actually looking at these new molecules and finding favor of their use in the prevention of preeclampsia. So I hope I've managed in the last couple of minutes to walk you through the entire journey of how you can work with a patient from the first time they present to you in your cubicle to be able to determine if they will actually benefit from these molecules or these agents that could improve or reduce their chances of getting preeclampsia. So thank you very much for your participation and your audience for listening to me. And I would like to hand over back to Dr. Bosire. And thank you very much, organizers, for allowing me to double task. I've been admitting people as well as present, so you must give it info to me. Thank you very much. Tell me what to do next to get the screens back to you.
All right, thank you, Dr. Sikolia. It was a very good presentation. We appreciate it. A couple of things we've learned today, of course, this thing called PAPA. It's quite interesting. I wonder whether we do this in Kenya. Is it possible for us to do this? Is it possible for us to do S-fleet? Because I do think S-fleet can also be quite an indicator for us. Several learning points. I think we'll talk about them as we go ahead. For me, most importantly, also is the role of the aspirin and the fact that you give it at night. I thought that was pretty interesting. point also that we should avoid, really, if you are committing to giving aspirin, why don't you just give it at 150 milligrams rather than the 75 that we routinely give? Let's stick to 150, guys. Coming up next is Professor Yulia Davydova. She's a professor, head of department in obstetric gynecology in the Institute of Pediatrics and Obstetric and Gynecology in Kiev. This is in the Ukraine, quite a big country, that one. She's also an expert advisor to WHO. And well, believe it or not, she has actually been a doctor even before I was a gamete. So that is a really long time ago. She's been practicing, I think, from the 1980s. Many of us were not born. Many of us maybe some of us were just in medical school. Maybe Professor Davi, I think. We'd want to invite Professor to talk about L-arginine and its role in prevention of pre-eclampsia, and especially those who I believe will be at high risk, those ones who we talked about with chronic hypertension, maybe with multiple gestations. Let her take us through. I know Dr. Sikolia needs to hand over the hosting to the Harleys team, or is it to her, so that she's able to present. Keep your questions. There are a couple of questions in the chat. We will address them. Once we are done with the presentation. Thank you, Dr. Sikolia, again. Fantastic presentation. Professor Yulia?
First of all, I want to thank everybody who is with us now. And I want to say the words of great appreciation for invitation for such an interesting conference. And thank you, Professor Sikolia, for the introduction for our theme, the role of L-arginine in the complex treatment of patients with preeclampsia and feto-placental insufficiency. First of all, I want to say a couple of words about what kind of recommendation do we use when we treat the patients with preeclampsia. It's, of course, the ISCardio and European Society of Hypertension guidelines of 2018. And there is peripatho management of hypertension. It is 2018 also. And in 2019, NICE guidelines concerned the hypertension in pregnancy about diagnosis and management. What is the difference and what is our interest for women with high blood pressure during their pregnancy? If the woman is normotensive in her pregnancy, she has low blood pressure just in the first trimester, and of course, very closely to menopause, she could have the hypertension. But I want to emphasize very closely to menopause. But if woman was pre-eclamptic during her pregnancy and had high blood pressure, her age for hypertension is about 35 or 40 years. And this is the group of high risk of cardiovascular damages and cardiovascular events in her 50s or 60 years of age. What are the risk factors for preeclampsia? Professor Sikolia spoke about them. And what are the main risk factors which are very important for our clinics for fetal maternal medicine for women with comorbidities? Of course, it's insulin resistance and diabetes, chronic hypertension, obesity, chronic kidney diseases, and our clinics have a lot of patients with systemic lupus erythematosus and other autoimmune disease. Of course, antiphospholipid syndrome, family history of preeclampsia, mother's age more than 35 age, and multiple pregnancy. And since 2018 and during the ISCARDIO meeting this year, 2021, the history of preeclampsia was included to the Framingham risk score, that very risk score scale, which we can use for everybody who want to know its own individual heart diseases risk. And after the special trials, it was considered that after the pre-eclampsia during her first pregnancy, in 30 years after this pregnancy, the risk of cardiovascular events is very, very high. If we compare the cardiovascular deaths of women with early severe preeclampsia, you can see it's very, very high. If it was the term preeclampsia, it was more high than in women without preeclampsia who had full-term birth. And on this picture, we can see the cardiovascular deaths in women more than 2 lifetime pregnancies without any kind of the hypertension. The level of the cardiovascular death was not so high. And so we are going to the endothelial dysfunction, which is a potential predictor of very, very wide range of the pathology during the pregnancy. It's potential predictor of, we say that pregnancy-associated cardiovascular diseases in future life. What are these cardiovascular diseases? Preeclampsia and gestational hypertension leads to congestive heart disease, arterial hypertension, atherosclerosis, and stroke in the further life of this woman. So in 2014, we performed the special trial, and we wanted to understand how the L-arginine, Tivortin, influences the concentration of the endothelial progenitor cells, the cells from which the mature endothelial would take the origin. And we evaluated this concentration in pregnant with hypertensive disorders and coexisting pathology before and after the supplement of the scheduled prophylactics of preeclampsia and treatment with the L-arginine. So we had 22 pregnant with systemic lupus erythematosus. We had 20 pregnant with congenital heart diseases who had the hypertensive disorders in previous pregnancy. We started the concentration of CD34 and CD45. Also, we used to check the SVLT-PLGF ratio into 10 to 11 weeks of gestation. And besides the scheduled prophylactics of preeclampsia, which consist of aspirin and calcium supplementation, in group 1, we implemented the L-arginine in doses regulated for cardiac patients. The group of comparison was created of 18 pregnant with the same pathology and CHD with previous gestational hypertensive disorders. What is the place of Tivortin? If we speak about the prophylactics by aspirin, it should be started after the 12th week. But if we are speaking about the prevention of preeclampsia, we had to use the medication much more earlier. And the best way is the preconceptional use of Tivortin in group of risks. Because just here you can see that from mesometrium, the endothelial progenitors would go to the mononuclear placental seat of trophoblasts, which would invade the uterine wall and its vascular system. During this process, it should be the appropriate transformation of spiral arteries into wide bore vessels that would perfuse the placenta. Afterwards, the arbor villi are covered with multinucleated syncytial trophoblasts, which transport the variety of substances to and from the fetus, ensuring the normal development of the fetus. And what they need the very strong endothelial wall. So we are going further. What we had, if the ratio of SVLT to PLGF was unfavorable, you can see then in group 1, the level of progenitors was 2.24. But after using a complex therapy with L-arginine, you can see it was as twice as high. In case of the favorable ratio of SVLT of PLGF, we had also the increase of the progenitors, but not so pronounced like in case of unfavorable ratio. And you can see the comparison group. In unfavorable, without prophylactics, it was a rise, but not significant and not appropriate for the feto-placental unit construction. And in case of favorable, situation was much better. We know that development of preeclampsia is stage 1, stage 2. The stage 1, there are the risk factors, but the stage 2, there are additional factors which would have the potential enhancement of the stage 1. And if we influence at the level of early pregnancy with Tivortin during the first wave of invasion of trophoblast and second wave invasion of trophoblast, we would succeed in the result of our pregnancy. We can say about our obstetric outcomes. The group of systemic lupus erythematosus. Well, in group which had additionally L-arginine, you can see the full term delivery was about 91%. And in group without L-arginine, only with the scheduled prophylactics of preeclampsia, it was 50%. The level of cesarean section. It was about 37% in group with L-arginine and 50% without L-arginine. And you can see the assisted vaginal deliveries in a group with L-arginine. There was no patients, and one patient in a group without L-arginine had assistant vaginal deliveries. What about the perinatal outcomes? In group 1, which had the L-arginine in the scheduled prophylactics, there was no newborns with fetal growth retardation and small for gestational age. In group of comparison, it was about 17%. Great difference. The Apgar score less than 7 points in group 1, we didn't have, it was 0. And in group of comparison, it was about 30%. What were our outcomes? The first thing is early prediction of hypertension disorders in pregnancy. Early prediction means that in high risk group, we have to prescribe the L-arginine during the 3 months of preconceptional period. We have to continue it during the first trimester and up to the end of the second level of trophoblast invasion. And positive influence on the endothelial function allows to obtain much more favorable results, even in control of the hypertension in high-risk group, because one of our aims when we are treating the patient with the preeclampsia is to obtain the control under the hypertension. And all of this resulted in the reduction of obstetrics and perinatal outcomes. As you can see, the reduction of preterm deliveries, including iatrogenic, abdominal deliveries, and assisted vaginal deliveries. So we have to repeat that all the risk factors for pre-eclampsia work during very, very early stages of pregnancy. And if we can influence just to spiral arteries remodulation and help them to obtain the significant amount of endothelial progenitors, which would mature to special endotheliosites, we would manage in the prophylaxis of pre-eclampsia. If we do so, we can prevent the second stage, the clinical stage, the clinical signs of the pre-eclampsia, which would be the consequence of vasospasm. It would be proteinuria, oliguria, it would be swelling, it is increased vascular permeability, hyperproteinemia, fluid output into the intercellular space, and all the consequences of the severe signs of preeclampsia. So, hypertension. We speak about the chronic, which is pre-existing, and in our clinics, we have a lot of patients with the pre-existing hypertensions, and we have a lot of patients with gestational hypertension, preeclampsia with severe symptoms, which we had after the 20th weeks of pregnancy. This is a very interesting picture about preeclampsia, gestational hypertension, what we have to check in those pregnant women, what about HELP syndrome, and what about eclampsia. This is a preeclampsia with grand mal seizure. And I have to say that during my last 15 years of my experience, and my experience in obstetrics is about 30 years, I don't have any patients with preeclampsia. What about preconception? Dr. Sikolia spoke about the vitamin D. If our patient has proved vitamin D deficiency, we supply her with 2,000 units of vitamin D. If we have the endothelium-dependent vascular manifestation, we have to supplement with L-arginine. Tivortin aspartate, 5 milliliters 3 times per day for 3 months. Very, very, very often in this group of patients, they have the deficient of the second phase of the menstrual cycle. In this case, we supplement with dydrogesterone 10 milligrams per day. And if it is iron deficiency definition, and it's proved by the special analysis, we correct the iron deficiency. So what was our suggestion? Tivortin aspartate 3 times per day, first and second wave of trophoblast invasion, aspirin 100 milligrams per day from 12 weeks, not later than 16 weeks to 36 weeks, and calcium supplementation. And I want to share with you some of our clinical cases. Now you can see the first woman. She had severe preeclampsia. She had preterm iatrogenic delivery. In her second marriage, she had 3 miscarriages as in early terms of pregnancy, and she had compliance of weakness and pain in her lower extremities. What do we had in this case? Pelvic ultrasound, hormonal maintenance of menstrual cycle, endometrial biopsy, no signs of chronic endometritis, TSH normal, antibodies to TPO normal, no antiphospholipid syndrome, no antibodies for antiphospholipids. Antinuclear antibodies are negative, but perinatal psychologist says that she has low stress tolerance and high level of anxiety. What should we give to this woman? We gave her Tivortin, we gave her folates, and we gave her Dufaston. And so during her pregnancy, we supplemented her with aspirin cardio, with Tivortin during the first and second wave of trophoblast. We gave her the psychological support of pregnancy, and she has a healthy boy in full term. The second patient, she's 36 years old. She has the second pregnancy. She has 1 childbirth, but in 26 weeks, she had severe preeclampsia. She had the abruption of placenta, urgent cesarean section, unfortunately stillbirth, and 1 miscarriage. Family history. Mother and sister has hypertension from 38 weeks of their pregnancies. Sister had mild preeclampsia during her 2 childbirths. Father has severe hypertension in the age of 52. So here we examined for the antiphospholipid syndromes, and we had the elevated lupus anticoagulant twice in 12 weeks. And also this woman had the congenital thrombophilia, the heterozygous of the factor V laden mutation. So we gave her aspirin cardio, we gave her warfarin. She obtained Tivortin in the preconceptional period, Dufaston, and training with the psychologist. This woman had the antiphospholipid syndrome. This is the ongoing case. Just now she has enoxaparin. She has aspirin cardio, Tivortin we used during her first and second trimester. We performed the dynamic cervicometry by the transvaginal ultrasound, and the length is more than 35 millimeters, and she has the Dufaston 10 milligrams per day. That's about our trial, our experience. Now I want to speak about the experience of our colleagues in Uzbekistan. And their usage of Tivortin is different from others. What was the purposes of their trial? there is no known cure for preeclampsia. The only known cure is delivery, but early delivery can put the fetus in high risk of the perinatal morbidity on mortality, which is strictly connected with their prematurity. So, the correction of arterial hypertension allows to reduce the maternal complications, but it's not always possible to achieve controlled blood pressure, even by the three medications used for the correction of hypertension. And antihypertensive therapy has no positive effect on improving renal function and placental blood flow. So it was spoke about the fetal restricted development syndrome, FRDS, and multi-system endothelial dysfunction. And in this case, it was suggested to use the Tivortin. The numerous randomized clinical trials proved that the reduction of AH and its effect on fetal stars have shown a rather high clinical effects. And you see, the leading cause of preeclampsia is dysfunction of L-arginine, a nitric oxide system. So the hypothesis of our own colleague from Uzbekistan was role of L-arginine in the prevention and treatment of preeclampsia. They had the systematic review of randomized trials. The effect of oral L-arginine supplementation on blood pressure. They had the meta-analysis of randomized double-blind placebo-controlled trials. And they had the study of role of L-arginine in the diagnosis of pregnancy-induced hypertension. As you may know, it is very well known, the publication of Kypros Nicolaides about the role of asymmetric dimethyl-arginine, arginine and homoarginine in the 13 weeks of gestation and preeclampsia, the case control study. And it was suggested that the reduced concentration of arginine, which are the substrates for NEOS system, could result in the impaired synthesis of nitric oxide. This publication and these trials led to including of L-arginine to the recommendation for Canada. The Society of Obstetricians and Gynecologists of Canada, that L-arginine, increased rest at home in the third trimester and reduction of workload could be useful in the prevention of preeclampsia. And you can see the level is 1B, just very high. And the second, we can speak about what are the mechanisms. How can the L-arginine work in favor of fetus in prevention of preeclampsia? They have found that L-arginine can improve growth hormone secretion, which affects the somatic growth of the child. Also, the L-arginine promotes the synthesis of polyamines, which can promote placental growth and development. Also, the L-arginine stimulates the insulin secretion, which is the main anabolic hormone on the fetus. And L-arginine finally improves the uterine blood flow in two ways. It can cause vasodilatation and has an anti-aggregation effect on platelets. So our colleagues in Uzbekistan worked with their colleagues in Russia, with the St. Petersburg State Pediatric Medical University, and they wanted to study the complex therapy with Tivortin and its influence on preeclampsia and how it can improve the following indicators. first of all, uteroplacental blood, fetal blood flow, and improvement of the growth rate of the fetus. You can see that the hypothesis of our colleagues from Uzbekistan was that in pregnant women with various obstetric and somatic pathologies, the use of L-arginine contributed to the significant suppression of systemic inflammatory response and endothelial dysfunction. And as early as 8 hours after the beginning of the correction of the revealed disorders, they tried to could have the result of the decrease of the number of desquamated endotheliositis, interleukins, and tumor necrosis factors alpha. And this is the background of activation of anti-inflammatory component of the immune system. So their trial was called Placenta, and the objective of their trial was to evaluate the effectiveness of L-arginine in the correction of the uteroplacental fetal complex, intrauterine development of the fetus and newborn in the early period of adaptation. It was a prospective double-blind randomized multicentral controlled clinical trials in the Republic of Uzbekistan, and it was under the guidance of the Ministry of Health of the Uzbekistan, including criteria: mild preeclampsia in 26-29 weeks of gestation and placental dysfunction resulting from the combination of chronic diseases, anemia, and urinary tract infection, where 535 women were included. Group 1 did not use Tivortin. The group 2 received Tivortin for 7 to 10 days, and the full amount was 4.2 grams. And the study included patients with the impaired uteroplacental fetal blood flow, grade 1B. So, stage 1, detection of preeclampsia before treatment, stage 2, after treatments in 7 days, and stage 3, the evaluation at 37 weeks of gestation. And as I will show you further, during the Doppler examination of the uteroplacental fetal blood flow, the initial parameters of the resistance index was considered as a violation of the uteroplacental fetal blood flow, was estimated of 1/5 grade. After the therapy on the 7th day, it was a stage 2 of this trial. You can see that it was much more favorable results in group 2 with Tivortin. If we are speaking about the resistance index of the umbilical arteria, it's also the much more favorable results. The improvement of blood flow and the decreased centralization of blood flow. So the studies which were carried in 37 weeks in group 1 showed a significant decrease in blood flow, and on the opposite side, after treatment with Tivortin, it was significant improvement in uterine blood flow and was observed in comparison with the first group. So we are speaking now about the results. Group 1, you can see the very high level of cesarean section, and in group 2, it was as twice lower amount of the cesarean section as in comparison with group 1, and much more vaginal deliveries. And when the colleagues from Uzbekistan analyzed the outcome of childbirth in the study groups, they found out the following correlation between the type of childbirth through the vaginal birth channel and by cesarean section. In group 2, it was 2.7 to 1. In group 1, it was 1:2. So the much more favorable results. The highest ratio of women in labor with the antenatal rupture of membranes was detected in group 1. And the percentage of women who received L-arginine during pregnancy and the outcomes was 4.5 times lower than the women who received the standard therapy. So, we have to go further. Something is wrong. Oh, okay. And what were the disorders in the group? The group without L-arginine, they had greater number of complications. And you can see the atonia of about 6%, bleeding about 6%, fused placenta about 6%, and the antenatal rupture of membranes about 45%. And you may know that it's a background for chorion amniotes. So average blood loss in all studied group did not exceed physiological blood loss, but in group 1, it was tendency for about 20% more blood loss compared to group 2. Therefore, taking L-arginine into the complex therapy not only prevents the risks of the pathological blood loss during labor, but also reduces the volume of the physiological blood loss. So you can see the weight of the newborns at birth. In group 2, it was much more than 3 kilograms, medium and 3 kilograms and 500 grams, and in group 1, the weight was more less. And according to the results, you can see the outcomes for the newborns. The level of 7-8 points of Apgar score is very high, and very low the Apgar score of 4 to 5 points in the group 2. So what were the results? Including L-arginine into the standard therapy at the end of the second and beginning of the third trimester of pregnancy allowed our colleagues to prevent premature placental maturation by 2.5%, 2 times less often foci of necrosis were formed in the placenta, and there was very low level of the fibrosis and dystrophic changes in this group also. So their result, not only the prevention of preeclampsia, but including the L-arginine into the therapy, significantly improved the uteroplacental fetal blood flow. You can see the figures. It improved the fetal growth rate and functional state of newborns. It allowed to decrease the perinatal morbidity and mortality. It was reduced the incidence of fetal distress, and it was much favorable early neonatal period of adaptation of newborns, and which is very necessary. It allows to prolong the pregnancy until the optimal term of delivery. And in this case, we find we meet the ends. In our trial, we also needed to the result baby to home. So to obtain the full term delivery. And their conclusion that treatment with L-arginine in women at the end of the second and beginning of the third trimester in women with chronic diseases complicated by placental dysfunction improved the perinatal outcomes and led to the decrease of number of premature births and distress of the newborns. And their suggestion that the use of L-arginine in the treatment of preeclampsia and correction of disorders in the utero-placental fetal complex significantly improves the utero-placental fetal blood flow, and this allows to prolong the pregnancy to the optimum terms of pregnancy. What were their suggestions? And for the clinical practice, that in women with a gestational age 10 to 32 weeks, with the high risk of development preeclampsia, 6 grams per day for a month orally, if necessary, repeat the course. After the diagnosis of preeclampsia and initiation of the treatment to reduce the hypertension before the 36 weeks of pregnancy, the L-arginine should be 4.2, 8.4 grams, 10 days, and orally 6 grams for 4 weeks. And used of L-arginine in high doses for a short period of time with the inconclusive fetus, intravenous L-arginine up to 12.6 grams for 5 days. And the optimal gestational age to correct complications of preeclampsia, they suggested it is from 24 to 36 weeks. So in this regard, after summarizing our experience and our colleagues in Uzbekistan, we have to say that supplementary treatment with L-arginine Tivortin may represent a new, safe, and effective strategy to improve the endothelial function in various pregnancy complications and patients with the concomitant extragenital pathology. Thank you for your kind attention.
But thank you, Professor, for the good presentation. It's quite enlightening. It's quite an interesting product that is being mentioned there. And I think it's something that I believe is in Kenya. Somebody has asked me that, question. Is it currently in Kenya? I think it is now in Kenya. And what I want to do is initially just invite the people who have actually made it possible for Tivortin to come into Kenya. This is a Harleys group, and the person who currently is to just give us a small introduction as to what's going to happen is Mr. Rajesh, is a marketing and sales manager of Harleys. We want to just give us a very, very brief presentation because I know we're staying out of time, and then we'll answer the questions. Mr. Rajesh, are you available? Can you give us a small rundown?
Yes.
Kindly
yes.
go ahead, sir. Okay.
Okay, I'll share my screen.
Meanwhile, Professor and Professor Yulia and Dr. Sikolia, kindly look at the comments at the chat. And there's some questions that are being asked there. Maybe just look at them and see what you need to answer so that as Rajesh is giving his presentation, we'll be able to go straight into answering the questions. Thank you.
Okay, mine is just brief because most of the doctors may know Harleys, but those who don't know, just a brief, maybe 2-3 slides. So basically, Harleys Limited, we are based in Nairobi. Our corporate offices are in Westlands, Nairobi. Yeah, so basically these are the multinationals that we work with. They're quite a big company. We do a lot of pharmaceutical, OTC, surgical, medical devices, and so many others. A brief company profile. The company was incorporated in 1953, then bought over by the current management in 75. As I said, We are a leading distributor and marketer of pharmaceutical products and various other range. And we have offices in Nairobi, Mombasa, Eldoret, in Tanzania, at Dar es Salaam, and in Uganda, in Kampala. That's a brief about Harleys. Coming back to Yulia Farm is a Ukrainian pharmaceutical group with a global outlook. The only one of the top 5 Ukrainian pharmaceutical company, which was founded in 1990, and they started their manufacturing unit in 98. So they are there doing most of the therapeutic areas. They have more than 600 registered products, and almost every year they are launching 20 plus products. They are there across the globe, more than 41 plus countries, and having more than 25% export. So this is a brief about Yulia and Harleys. Just that I would like to mention about the product that was in discussion today, Tivortin, especially as you all know that it is created for the physiological cause of pregnancy, mainly because children must be born healthy. So actually I wanted to discuss about the conditions, maybe because most of them have heard about Tivortin and there would have been a lot of questions in the mind. So basically for placental deficiency in setting of habitual miscarriage, pre-eclampsia, endocrine dysfunction, and extragenital disease, it is recommended to be given between 4 to 28 weeks or between 32 to 34 weeks. So the recommended dose is Tivortin IV, which is 4.2 grams of L-arginine given for 10 days, just once a day. So it can be, the patient can come and she can take it as an outpatient, followed by Tivortin solution, 10 ml 3 times a day for 14 days. So the total regime is 10 days of IV, followed by the syrup for 14 days. For preeclampsia, it is recommended between 22nd to 37 weeks. Again, the therapeutic regime is Tivortin IV, 100 ml for 10 days, 10 to 15 days, followed by the oral solution, 10 ml given 3 times a day for 14 days. For prevention of preeclampsia in pregnancy with aggravated obstetric history, we're recommending it to be given between 14 to 32nd week. The prevention regime is Tivortin administered 1 gram daily, and followed by the syrup 3 times a day, 10 ml for 14 days. For high-grade pulmonary hypertension, it can be given throughout the course of pregnancy, starting with Tivortin IV once a day for 10 days, followed by the Tivortin syrup, 10 ml 3 times a day. It could be given whenever needed. Whenever you find there is an indication, it could be given for 10 days of IV, followed by 14 days of the syrup. In threatening miscarriages in setting of aggravated history, habitual miscarriage, gynecological disease, endocrine dysfunction, multiple gestation or in vitro fertilization, it could be given between 12 to 36th week. The same regime, Tivortin IV, 100 ml once a day for 10 days, followed by the oral solution, 10 ml thrice a day for 14 days. So most of it, it is recommended to give maximum up to 37th week, not beyond it. So, I mean, the early detection is much better, and once it is started early, the results are much encouraging. So that's it. One more thing, Dr. Yulia mentioned about preconception counseling and preconception training of women with hypertensive complication, where Tivortin can be included apart from vitamin D and the other regimes. So that's what, just to conclude, the sequential therapy of Tivortin IV followed by the syrup. That's what the dose we mentioned. 100 ml slow infusion given once a day, 5 to 10 days, followed by Tivortin aspartate, 10 ml thrice a day for 14 days. So actually, thank you so much for everyone for giving your valuable time. Thanks, Dr. Sikolia, for a wonderful a presentation followed by, Professor Yulia as well. Now I think Dr. Bosire can take the question and answers. I hand it over to you, Dr. Bosire.
All right, thank you again. Harleys has been a company that has been around for a while. Supports a lot of gynecology products. I think the one that is most famous with the brand of products. But of course, they're bringing for us something, the arginine product, and it's something that I feel is important. Questions in the chat. I think Dr. Sikolia, you want to answer your set of questions first? The host can also unmute Sikolia currently. Okay, and meanwhile, Dr. Moledina, I know wants to ask a question. Maybe kindly you can also unmute him. Sorry, Dr. Sikolia. I know Dr. Moledina has put his hand up for quite a while. Dr. Moledina?
Yeah, thank you very much for an excellent presentation. I was just wondering, because of this study, anybody has done any studies use of arginine before conception, where the history is of habitual miscarriages and loss of pregnancy in the past? Is there any study which has been done, or you think there is any role of arginine before conception for such patients so that we can have a safe delivery?
Harleys team, you can unmute Professor Yulia, because I believe she'll answer that question. Unmute Professor Yulia, please. Professor?
Okay. Do you hear me?
Yes.
Okay. Thank you for your interesting question. Our colleagues from the Gynecology department performed the special trials for the so-called thin endometrium. And they used the Tivortin in case of the miscarriages, which were combined with this thin endometrium. And they obtained a very encourageable results, and they presented it last week in our national conference. So they did have the experience for women with the steroids and with the miscarriages, which are the origin of which is the pathology of endometrium.
And what doses would you recommend preconception, in preconception?
In our trial, we use Tivortin for 5 milliliters of the syrup 3 times per day for 3 months.
Any lab work you have to do before you complete the doses, like maybe renal function or anything you would stress on that one?
And before the prescription of Tivortin, we had a full examination of our patient, including, of course, the renal function, especially in case of systemic lupus erythematosus, or in Uzbekistan in patients with some kinds, with kidneys diseases. And in case of systemic lupus erythematosus in our patients, the inclusion criteria was 6 months in the remission for the systemic lupus erythematosus. That means that they have the perfect or normal renal function. In case of impaired renal function, they were not allowed to plan any pregnancy.
Thank you very much.
Thank you very much. Dr. Sikolia, the questions were coming to you. Kindly unmute, host, can we kindly unmute Dr. Sikolia? The question was, I see the first question is, what value, the main question about the mean arterial pressure is there a value, is there a range that we have that says that this is automatically a patient who's at risk of getting preeclampsia? I don't, go ahead, sorry.
Yeah, thank you. That is Huron Tom for that question. No, I think that was Yusuf, and so it was Yusuf. So and Guaco. So the thing is, I think we're moving away from absolute values, and we are looking at ranges. And in pregnancy, remember that things move on with gestation. So what you need to do is once you have you get your value, then you input into the calculator, which will then give you your multiples of median for that particular patient, because it's taking into consideration the gestational age, the characteristics of the woman, the age of the patient, and all that, to be able to calculate the MOMs for that particular patient. So I'll encourage you to use the calculators instead of sticking to one particular value. And I think Dr. Soti has shared that link in the chat. And thank you, Dr. Soti, for that. Maybe I'll just proceed since I've been looking at the charts. There is a question from Dr. Soti again on the prediction, the charts I was showing for the prediction of preeclampsia. I think all those charts were looking at early onset. So we're looking at preeclampsia, preventing preeclampsia before 34 weeks. So all those are predictive from 50% to 90%. All those refer to preeclampsia before 34 weeks. Someone asked a very interesting question here on Tom about BP medication on a patient with preeclampsia with normal blood pressure. I didn't understand that, but I thought maybe what he meant was, would you continue the medication if the patient has the BPs have normalized? Initially, the answer is yes, because I've seen a tendency whereby you treat a patient who's coming with preeclampsia with severe features, who has high blood pressure, and then you get normal values, and then you want to stop the medication or reduce the medication. The thing is that you have achieved your goal, so you should maintain the medication at that particular level until the patient delivers, because you know very well the ultimate treatment for preeclampsia would be delivery. I don't think there were any other questions on the chat that addressed my presentation. So maybe Professor Yulia can take over. Thank you.
Okay, Professor Yulia, there's some questions on the chat. I don't know that you've gotten access to the questions. I could read them for you.
I found out only the question about can we combine the antihypertensive medications with the Tivortin. Of course, yes. It's a great support for our antihypertensive therapy. What about methyl-dopa? Methyl-dopa is the first start of our antihypertensive therapy in our country. If it doesn't work, we have to add the B blockers or nifedipine-corinfar. And in case of the resistant chronic hypertension, we can change this therapy to amlodipine. One medications, two medications, or three medications we can use in order to achieve the control under the hypertension. And as to our experience, in case of early use of Tivortin during the first and second trimester in our trial, we obtained the favorable influence of the antihypertensive therapy. And our colleagues in Uzbekistan used Tivortin in the end of the second and the beginning of the third trimester. And according to their randomized trials, they also had more favorable influence of the antihypertensive therapy.
Yeah, maybe can I ask a question while you're there? You're still on the floor. The presentation from Rajesh, I think, is showing about the sequential treatment where you use the IV followed by the oral solution. Do you have any experience or any data to show whether you really need a combination or whether one, maybe the oral solution alone is as effective as using both?
You see, in our country, we pay great attention for preconception. We have a low level of the deliveries for one woman. So every pregnancy in our country, no, we want it to be planned. In case of the previous complications, or in case a woman has severe comorbidities, she used to plan her pregnancy. So the target of our trial was preconception and first trimester. Obviously, we used the oral syrup. The colleagues in Uzbekistan, they didn't deal with the preconception. They had to deal with the woman in the second trimester of pregnancy. So they had to use their oral syrup and they use the intravenous Tivortin. And they obtained the great results in this combination. So called the intravenous plus oral Tivortin.
Okay, thank you for the answer. Professor, a question also on the chat. Dr. Baer asked, does L-arginine lower the progression to eclampsia? Is there such a thing as, can we use it to prevent progression from pre-eclampsia to eclampsia? The other question is that, okay, we've asked that, sorry, I just want, you can answer two questions. Okay, you can answer that. Can it prevent progression to pre-eclampsia?
Okay. If we refer to the study of our colleagues from Uzbekistan, they include in their study the people with mild preeclampsia. And they studied the mild preeclampsia. In our trial, we dealt with women with severe pathology, and we wanted to prevent the superimposed preeclampsia. So the targets of our trials were quite different, and as in our situation, as I show you, we didn't have the severe superimposed preeclampsia. So it could be prevented in women with the comorbidities, which could lead to the superimposed preeclampsia. In the study of our Uzbekistan colleagues, they clearly showed that they didn't have the progression to the severe preeclampsia, and it was proved by the high incidence of the full-term deliveries.
Okay, thank you for that. We'll take a question from Otto. Host, can you kindly unmute Otto and Irina also? They have put their hands up, and then what we'll do is answer the question on the cost of the Tivortin, and then we'll bring the session to an end.
Okay, I want to answer questions about term using Tivortin intra-pregnancy. From our experience, our study, we can recommend using Tivortin before 36 weeks of pregnancy, and cannot use before delivery. It was last question.
Okay, thank you for that. Patrick, did you have a question? Unmute. Host, kindly unmute Patrick.
Everybody can unmute because we have given access. Just unmute and ask.
Okay. Patrick, unmute yourself.
Hello.
Go ahead, sir.
Good evening, everyone. Patrick from Harleys, Uganda, representing Urea Pharma. All the products of Urea this side in Uganda. Actually, I would like to ask a question about Tivortin in particular, its benefits and effects in erectile dysfunction. And maybe in case of pediatrics, I would want to know how it works in people with sickle cell anemia.
Okay,
thank you.
Professor, let me just answer that for him. We're trying to just focus on obstetrics currently. Things of erectile dysfunction, maybe I'll send you to urologist to agree.
I will answer to Mr. Patrick for this.
Bozire, let the answer come, please, if it is there.
Yes,
okay, Professor.
And we'll talk with him about rectal dysfunctions. If it be shortly, it's very good effect for treatment rectal dysfunctions, but maybe it's topic for next conference.
Okay.
Okay, so thank you. So the last question that's being asked is cost. Is the cost prohibitive? I don't know that Rajesh has left already, so that we can know the costs. But is it available in the country?
Yes, it's available, very much available with us. And only thing is that we have not made it so freely available, because I know that it's not an OTC product. It has to come with prescriptions. But as and when needed, it's very freely available. We can even deliver wherever needed to the patients. We have been doing that selectively, meaning to the patients who need. So we have not made it, because we distribute to more than 4,000 plus customers. So we can't make it available everywhere. But any patient, call us, within few hours, the patient can get it.
Okay, thank you. So we must give our thanks to Professor Yulia, all the way in Ukraine. We really thank you for taking your time to spend to answer our questions and to educate us about this product. Thank you, Professor. And we would kindly like to have the presentation shared, possibly through Rajesh and his team. Dr. Sikolia, thank you again for being a leading light in our country. We appreciate it. Again, kindly share the presentation. Guys, kindly start getting friendly with these online calculators. I think they are important. The day of using the wheel, calculate the station by dates, for example, please, it's gone. Start using these online calculations. I think Dr. Soti shared one. To Harleys Pharmaceuticals, thank you for today. We really appreciate, and we do want to wish everyone a good night. Thank you for participating in the webinar today. I believe it's CPD accredited. You should be getting your points. Yes, thank you very much.
Thank you so much.
Thank you very much, and good night.
And all of you.
Thank you.
Bye.
Thank you. Had a great time. I had a great time with you. And
thank you, Professor.
I wish everybody all the best and good patience.
Thank you, and good night, guys.
Thank you, Dr. Sikolia. Thank you, Dr. Bosire.
Thank you. Good night.
Dear Doctor, we need your opinion and your experience using this product. We will happy work with everybody.
Thank you.
Dr. Irina, when are we having Tivortin in Uganda, the rural population?
In Uganda, you have Tivortin in Uganda now in store in Harleys, but next month you will have the syrup forms.
Syrup, okay.
Okay, but we recommend to begin from IV solutions. You will have very fast results, and you remember about bioavailability IV solutions.
Okay, please.
I think we can close the flow, because maybe those things can be individually discussed. Yeah. Thank you so much. Thank you so much for everyone. Thank you all doctors for participating in a big number. Thanks a lot, and good night, and take care.